So I'm going to just add on to Dr. Dua's presentation. So to present a novel sirolimus drug-eluting balloon and what it can bring to patients. So just in recap, historic data, so far 4 drug-coated balloons and 1 drug-eluting stent using paclitaxel have failed below the knee. So now let me say this too, that maybe it's secondary to the drug, maybe it's secondary to a stent, maybe it's secondary to the balloon, maybe it's secondary to trial design, okay? So, but the only thing I know is these are the results to date, and so at least in the United States, we have very little except for coronary drug-eluting stents that we can use below the knee. The below-the-knee challenges. So if you look at the pathology of the lesion, right, we know there's small vessels, similar to coronaries, 2 to 4 millimeters typically, but the pathology of the lesion's different. It's very different than almost any other vascular bed. It's different than coronaries. It's different than above the knee. You have this typical calcific layer. It's not only in the intima, but it's also in the media. But not only that, you get this soft thrombotic type of plaque. So we have to adequately prep these vessels before you deliver a biologic, right? Before you deliver an anti-neoproliferative, whatever that may be. So when you look at this sirolimus unique pharmacokinetic profile, I stole this from Dr. Dua's slides. Remember that limus is cytostatic and paclitaxel is cytotoxic. Limus is a potent anti-proliferative agent, immunosuppressive anti-inflammatory agent, and a cell anti-migratory agent. In addition, it limits apoptosis, and this was eloquently said by Dr. Dua. So again, I stole this from hers as well. You've seen this slide a million times, the differences between limus and paclitaxel, cytostatic versus cytotoxic, the therapeutic range being wide with limus versus narrow with paclitaxel, the margin of safety being greater with limus versus paclitaxel, and several others. Again, so Dr. Dua outlined for us in this slide, so what are the challenges and what do we need to overcome when we're developing a limus drug-coated balloon or a drug-eluting balloon? So you need to have increased drug uptake, as she said, extend the drug retention, and limit the drug embolization. So I'm going to introduce to you a solution, and some of you in the room have used it. In Europe, it's out. It's a sirolimus eluting balloon. Remember, there's 2 things that are special about this balloon, and I just want to mention this too. So we say there's difference between paclitaxel and limus. There's also differences among classes, right? So we know very definitively that paclitaxel drug-coated balloons, there's differences between it, whether you're using elutonics, whether you're using an impact. Also, there are differences with limus drug-coated balloons. I'm going to show you the things that are special, especially with solution. Number 1, it has these MicroReservoirs. It has in these MicroReservoirs a biodegradable polymer and molecular limus. It's not crystalline, it's a molecular-based limus. In addition, it has this proprietary cell-adherent technology. Now, what does this do? Well, this cell-adherent technology holds these MicroReservoirs on the balloon. So when you're going to the lesion, it keeps these MicroReservoirs on the balloon so you can treat it, so you just don't start losing the MicroReservoirs. In addition, it allows you, once you get to the lesion, you blow the balloon up, for it to attach to where the lesion is, such that these MicroReservoirs with this biodegradable polymer can slowly elute this limus over, and we've done some studies looking out to 90 days, similar to stent technology, over a period of time so that you can deliver this limus to the media and adventitia where the smooth muscle cells are, okay? Remember, again, and I'm just going to emphasize this again, below the knee, the pathology is different, so you need to adequately prep these vessels before you deliver any type of anti-neoproliferative. So prep the vessel, and then with this, we would deliver a solution sirolimus eluting balloon. Again, this proprietary MicroReservoir technology has a controlled and sustained sirolimus drug-eluting effect, and this shows us out to 60 days. It's actually out to 90 days, comparing it to both Medtronic and the Lutonix paclitaxel drug-coated balloons. As you can see here, With this proprietary cell-adherent technology in these microreservoirs, you don't need as much limus. So first of all, let me show you here, comparing across the x-axis is your Med-Alliance Sirolimus drug-coated balloon. Next is your Bard Lutonix paclitaxel balloon, and the third is your Medtronic paclitaxel impact drug-coated balloon. The red here is the amount of drug that is lost getting to the lesion, right? This, what we in the literature we call transit time, because it starts eluting drug. So as you can see here, more drug is held on with the limus drug-coated drug-eluting balloon. In terms of the yellow, it's retained on the balloon, again, so you're delivering more drug to the lesion. And then the third thing is how much is transferred to the vessel. Because of this microreservoir technology, you're able to transform more drug to the vessel such that you don't need to put as much anti-near proliferative on the balloon. And this allowing for a lower dose on the solution at 1 microgram per millimeter squared. All right, so the other thing we've talked about is this proprietary balloon coating technology. As you can see here, one of the things is, and we always talk about this with the paclitaxel drug-coated balloon, some people call it the whip test or whatever, you shake the balloon, you can actually see the paclitaxel coming off the balloon. In some Sirolimus drug-eluting balloons too, if you shake it, you can see it. You don't see hardly any flaking, if any at all, with the solution Sirolimus drug-eluting balloon. The other thing that's important is this cell-adherent technology. The crystalline structures on the paclitaxel drug-coated balloons are rough, right? It's not as smooth as the solution drug-eluting balloon. So many a times when you're delivering this balloon to the lesion, it's easier because it's smoother with the cell-adherent technology in the limus microreservoirs. Also, if you look downstream, so these were actual pictures of a embolic protection placed down distal to before the balloons were blown up. And as you can see, to the left here is impact, to the right is Lutonix paclitaxel drug-coated balloons. You get these large chunks or larger chunks of drug compared to the middle, which is the solution drug-eluting balloon with sirolimus. As you can see, these large yellow bright chunks are part of the balloon paclitaxel and excipient that have gone downstream versus the solution. In terms of slow flow, remember, before I get into this slide, that there was a Japanese study. It was Journal of Vascular Surgery 2017. And what it showed us is that people who had slow flow, it was indicative of poor healing rates and increased amputation. Now, what this slide shows us, granted it's not an active movie, but you get the impression that the flow is good and there's no slow flow. But as you can see down there on the graph, what the graph is on the y-axis, it's flow versus rate on the x-axis. And as you can see here, this nice bell-shaped curve shows us that it has good flow and it's not slow. Now, let's get into the evidence. So there's a large amount of evidence. There's about 1,900 patients studied so far with the solution Sirolimus drug-eluting balloon. It's been studied not only in the SFA, but we're also studying it below the knee and also in the foot, in addition to the coronaries, in addition to AV fistulas. But in terms of the peripheral, as you can see, are a huge range of evidence. In the first trial that we looked at with the first-in-man study, led by Thomas Zeller, it was 50 patients, and the primary endpoint with angiographic late lumen loss, as well as multiple safety endpoints. And as you can see here, the data show at 6 months, in the 6 months with an angiographic endpoint and then ultrasound at 12 and 24 months, the primary patency was good at 6 months at 88.4%, 24 months 81.6%, very safe. And as you can see here to the right, the target lesion restenosis was about 88%. Again, very good results in terms of above the knee. In terms of the below the knee experience, there are 2 trials to date. Both, one was a Prestige and one was the Pristine, 25 patients and 75 patients. The Prestige has 18 months of follow-up with a primary endpoint of freedom from device or procedure-related mortality at 30 days and the freedom from target lesion revascularization both at 6 and 12 months. And then the Pristine, 75 patients, primary endpoints, again, very similar to the Prestige, but just freedom from clinically driven TLR at 6 months post-index procedure. In terms of the results of both of these, Prestige, as you can see, all of them were Rutherford 5 compared to Pristine, which included about 25% or 20%, which are actually Rutherford 6. So a sicker population, more calcium in the Pristine, and a higher risk of amputation compared to Prestige. But the outcomes were both very good. The freedom from TLR at 93% in the Prestige and about 84% with Pristine. And again, high rates of amputation-free survival, which were similar in both. Primary patency rates were very good, and wound healing rates were very good. And remember, again, a very sick population in Pristine. In terms of recently in the United States and also in the United States, the first IDE trial with solution has been approved, and we're currently enrolling 377 patients in 40 sites, not only in the USA, but also Europe, Singapore. Follow-up is out to 5 years. And the primary endpoints, both efficacy and safety endpoints. Efficacy, as you can see, is a composite of freedom from target lesion occlusion, above the knee, ankle amputation, clinically driven target lesion reintervention at 6 months. And safety, major adverse limb events, all-cause perioperative death at 30 days. This is the flow chart for enrollment in the solution below the knee trial, as you can see here. You can treat inflow as long as you have a good result with treating the inflow. You can then focus on the below the knee lesion. You prep it adequately, okay? If you have a good result in terms of prep for below the knee, then you can randomize to either solution or plain old balloon angioplasty, as seen here. In conclusion, or the take-home messages from this is that solution, Sirolimus drug-eluting balloons, is a new generation drug-eluting technology. It has Sirolimus, which is an anti-restenotic agent, very eloquently discussed by Dr. Dua. Has a sustained drug release out to 90 days. Low drug because of the cell adherent technology in these MicroReservoirs. Smooth coating, improved delivery, and small homogeneous particulates. Both the Pristine and Prestige studies have shown early promising results, and we look forward to learning more with the solution for below-the-knee randomized controlled trial, which was recently approved and currently enrolling, comparing the solution drug-eluting balloon to plain old balloon angioplasty and below-the-knee disease. Thank you very much for your attention.